to Professor Sherene. You can go ahead.
Right.
So,
Today we have the phone call. We have 5 phone calls, so we start one by one. Carlos, are you ready? This is a famous phone call of the oliguria after right hemicolectomy.
yes. Are you ready, Dr. Corollos, or are you on call today?
We can wait, no problem.
Yes, something with
By
his
the way,
voice.
we will start exam in Malaysia tomorrow. You can read it, or shall I read it? No problem. It is, you are Dr. Richard, SHO, Senior House Officer for Mr. Wolfson, who will be called Mr. Browse, so is another doctor, the consultant in charge for today, to tell him about a case is not under his supervision. Vital signs, blood pressure is little low, pulse 120, temperature is 37 degrees centigrade, abdomen lax, no blood in the drain. Patient have bleeding during surgery and take 2 units of blood and 1,100 milli of normal saline. Hemoglobin was 12 and dropped to become 10 after surgery. Urea is 9, which is little high, and the creatinine is 2, which is little high, and the potassium is 3, which is normal. I leave the screen and you can start how to start.
I need to know what is the operation type.
No, it is in heading. It is a case of the right hemicolectomy. This is the first slide. It is oliguria after right hemicolectomy.
Okay.
Of course, in this station, you have preparatory station. In this preparatory station, you have big file contain all data of the patient, vital sign, operative details, drug chart, all this. Okay.
Okay.
Here, Dr. Carlos, the aim of the station is you are able to grab the main items of this patient and to communicate well with the consultant. So the area that you should be concentrate, tell him about a case which is not under his supervision. So he wants you to grab information, speak to the consultant. This is not his patient. And this is very good station to test your skills of grabbing important
It's very
information.
common.
Go ahead.
Use it.
It's very common, yes. And it's very difficult. Go ahead, Corollos.
Okay. I am Wolverson. I am
No, you are
CHO.
Richard. You are Richard and working with Mr. Wolfson.
Okay, I'm sorry. Okay, good evening.
You can say I'm Carlos, no problem. Just any name, but you just explain to me you are working with Mr. X and you call another doctor. Okay, go on. Start.
Good evening. I am Richard, SHO. I am working for Mr. Wolverson, and I am calling to about a patient of he has right hemicolectomy and.
This is my patient?
No, it's not your patient, sir. It's a patient of Mr. Wolverson, and I need your advice. I'm seeking your advice.
You need to tell, can I confirm that I am calling the consultant on call, or I calling Mr. Browse? Yes, I am Mr. Browse. Okay? All right. So can you tell me about the case? I just need some data. No, this is a case, is about 65 years old. The patient have oliguria after right hemicolectomy. Okay? So can you tell me what you need to do, or what happened, or what can be the cause? We can start. I will ask you some question. You can present the case. But what is, you say it is oliguria. So what is the normal urine output?
It's 1 milli every kilogram for 1 hour per hour.
Okay. 1 milli per kilogram body weight per hour, and this patient may be about 70 or something like that. So what you mean by oliguria? You mentioned that this patient have oliguria after right hemicolectomy. What you mean by oliguria?
His urine not
is less than normal value, which is 1 or half milli per kilogram body weight, or in some book, if we collected per day, it is less than half a liter. All right. Okay. So can you tell me what is the causes of oliguria in general?
Hypoperfusion of the kidney. It's acute kidney injury, chronic kidney injury,
Can become more
trauma.
classified because can be make it like perirenal, renal, post-renal cause, and we apply to the
Perirenal,
patient.
it's perirenal. It's like hypoperfusion of the blood or thirsty
Okay,
or
so we
hypovolemia.
speak about that later. So we have perirenal, renal, and post-renal. Okay, so we start by post-renal cause. In this patient, how to check for post-renal cause?
Sorry,
How to check that the patient have no post-renal cause? You mentioned that you have perirenal, renal, post-renal. How to check for post-renal?
Yes, I will by ultrasound and I will
No, not
introduce
ultrasound.
catheter.
Something, think simple. Yes?
Catheter.
What you mean by catheter?
Urinary catheter.
You already, the patient have a catheter. So what you need to check?
The chart of the fluid.
No. Still one by one. First, you need to check that the catheter is not blocked. Okay? If the patient have no catheter, but this patient, because post-operative has a catheter inserted, so the first to exclude post-renal cause, like block the catheter, so you can flush the catheter. Okay? So, of course, if the patient have no catheter, you need to check for prostate and all this. All right. So, you mentioned we have renal and pre-renal. What about renal cause in this patient? What you expected the renal cause? Not in particular. What you need to look in the patient file to exclude renal cause.
Sorry, the internet is not good.
Okay.
Can you repeat, doctor? I'm sorry.
All right. We have in this patient how to exclude the renal causes.
By kidney function test.
Okay, so you're looking for kidney function test. What else?
By fluid chart and
Flow chart is for pre-renal, not for renal. A flow chart is the end, is the answer, but we started step by step. To check the renal cause, you need to look in for chart medication chart. You have a chart for medication just to exclude any nephrotoxic drug like some aminoglycoside or antibiotic. Okay, and of course, looking in the history, if the patient have any history of the kidney disease, and this patient have no history of kidney disease. Okay. By the way, in this station, in the preparation station, and in the same room, you have the complete file of the patient. Okay. So back again. So the vital sign of the patient is 100/80, pulse 120, temperature 37 degrees centigrade. Abdominal examination, abdomen is lax, as we mentioned, no blood from a drain. Okay. This patient have no colostomy or ileostomy. Although have, if we see the patient operation, the operation is oliguria after right hemicolectomy. So why this patient have no colostomy or ileostomy?
because
It is correct or some mistake, or what is your opinion?
I don't know.
Okay, because in right hemicolectomy, we don't do ileostomy and colostomy. We do colostomy and ileostomy in the left hemicolectomy, not the right hemicolectomy. Right hemicolectomy, we just make anastomosis between ileum and transverse colon. Okay, back again, laboratory investigation, hemoglobin is 12, urea high, creatinine is little high. Can you check for operative notes? Why we need to check for operative note if patient have oliguria?
To see if any bleeding or any
bleeding okay happened and the patient take 2 units. What else you need to check? Suppose this patient is hysterectomy, for example, what you need to check?
If he's anemic or something.
See what?
If he If he is anemic,
he already anemic because they have a bleeding and they take a blood. But what we need to check, why this patient, why we need to check operative details. Suppose this patient, a female, have hysterectomy, and after hysterectomy have oliguria, or colectomy, after colectomy have oliguria. Apart from bleeding, what else you need to expect it?
I might have a rotatic injury.
Yes, so it is important to know that ureteric injury can be the cause, and usually if happened, we write it in the operative notes. So it is important to know the operative notes. Of course, in this patient have a bleeding, this patient take a blood, and this patient have no ureteric injury, but we check for that. Okay, so this is the next question to check for. Of course, we check the fluid chart. In some countries, they call it IO chart. The patient, when you see the notes, the patient only receive 1,100 milli. So from this all history, what you expected this patient have pre-renal, renal, or post-renal?
I think this patient has perirenal because he has a bleeding, active bleeding.
Okay, so which chart of our chart you need to show it? I show to you.
I need fluid chart and.
Okay, so this is a fluid chart. You can see input and output, and you can see the patient is only received 1,100 milli. So what is your opinion now? What is the cause? Is pre-renal due to dehydration or less fluid? Okay, so this patient is bleeding now. What is your opinion? In bleeding or not in bleeding?
He is in bleeding.
No, now it's not in bleeding because you're looking in the scenario. The scenario usually in front of you is the patient have a drain, and drain, nothing come from the drain. Okay, so this patient have a bleeding interoperative, but now have no bleeding. Okay, abdomen is lax, no blood from the drain, blood pressure is not decreasing much, but it is also indicates the patient is dehydrated. Okay, all right. So if you insert central line, so what you expected if you see this curve? Which curve you can notice in this patient? First one, second one, third one. Hypovolemic. So hypovolemic one. So this is the curve. After that. At the end, you need to summarize what you need to tell me.
I will give the patient fluid, crystalloid fluid, fluid challenge, and after this I will give, if not he respond, I will give him blood.
Okay.
Blood.
So what is your guide for all this?
CBC, if the hemoglobin is than 8, I will start blood. Before this,
blood
I will
transfusion, yes, okay. And also you're looking for any sign of bleeding. You need to call me again. You call me again or not?
I will call you again if the patient not responding to this fluid challenge.
No, just even if the patient improve, just to call me again. At the end, what you need to tell me.
Thank you for your time.
Thank you. So what we need, this is common scenario, and actually is difficult scenario. I attended maybe 20 times, and usually the student not pick this patient have a problem in fluid chart, and usually because if you see from the beginning, these patients only take normal saline is take only about 1 liter or 1 liter and 100, so it is very little amount in operation, and this can explain this patient have pre-renal cause. Of course, the patient have a catheter, and you can check the catheter. The patient have a drug chart. You need to check that no nephrotoxic drug is giving. It is the value of this station, or the aim of this station is just to know have many chart, and you need to looking for all these chart. Like you need to looking for operative chart to exclude injury of the ureter. You need to looking for the fluid for operative chart to looking for any injury of the ureter if happened, of course not. And also you're looking for input and output chart. You're looking for vital sign chart. You're looking for the drug chart. Each of this chart is inside the file of the patient, and usually each one in different color.
Just have a quick advice to Dr. Carolus. Number one, you missed the first point, which is to confirm whom you are speaking to. And this is common mistake. Although you will be in a room, you will pick up a phone and the consultant be on the other line. But you have to check who I am speaking to. This is number one. Number two, always keep your answer, Dr. Carlos, answer with confidence. If you give a hesitation, you're not sure. So try to get an answer with confidence. Number three, this station is difficult because you're asked to grab information from different parameters, different bits and pieces, and come with a conclusion. That's why they give you 9 minutes in the room before, what's called preparatory room, to prepare your answer. So maybe a little bit you're unfortunate that you didn't think about it or prepare yourself, but we can do it in the next time to give you maybe 5-6 minutes to read the scenario and then answer. But always answer with confidence. This is the passing mark. So we can have another volunteer who would like to volunteer for
Okay.
phone call
Thank
4.
you, Doctor.
You're welcome.
All
Now,
right,
best of
thank
luck.
you.
Good
Okay.
evening, Dr. Sherene. I can volunteer if you may.
The next scenario is a bile leakage after laparoscopic cholecystectomy, and the scenario is you are Richard, the candidate, his name is Richard, and you work with Mr. Wolfson, and you speak to another doctor.
We
which
don't
is
see
Mr.
the scenario, Professor Sherene, which
all
is the
right,
next slide.
okay.
You need to
Okay,
press.
I share the slide again.
I can see it.
We can see phone call
Okay.
4, but we don't see the scenario.
All right,
You
okay,
need to
I share
press on
again.
the next slide. Yeah.
Okay.
So
Okay. So you see this now?
not yet.
Yes, we can see.
Can you see it? Okay.
Yes, I can see it.
No, we
Okay.
don't see it. No. You need to share screen again.
I can
Yes.
see it, Dr. Sherene.
Now you are sharing screen and we don't presenting, but we see your image. We don't see the
Sure.
Dr. Mohammed,
the PowerPoint.
I think
Consultant in charge today to tell him about the case. So again, the case is a bile leakage after laparoscopic cholecystectomy. This is the scenario: is 45 years old woman underwent laparoscopic cholecystectomy yesterday by Mr. Wolfson. She complained of abdominal pain. Bile come from the drain. No change in the urine color. On examination, her abdomen is lax. Tinge of jaundice. Temperature is 38. Pulse 110, blood pressure 130/80. Abdominal ultrasound show minimal intra-abdominal collection, no intrahepatic biliary dilatation. Bilirubin is 15, which is normal. Okay, I leave this
Okay.
scenario, just you can start.
I forget the name of the doctor.
You are Richard. If you forget the name, just tell your name.
Okay.
Okay.
Good evening. My name is Dr. Muhammad Avhan of SHO for surgical doctor. May I
Okay.
confirm that I'm talking to the surgical consultant?
Yeah, I am Mr. Brown, the surgical consultant in call today.
Good evening, Mr. Prowse.
evening.
Can I take time of your time?
Okay, can.
I'm talking to you about a case of 45 years old.
This is my case or case of other consultant?
No, it's the case of Mr. Wolfson.
Okay,
Case?
so why you call me?
Because you are the consultant of the day.
All right, okay. So tell me.
It's a patient, 45 years old, underwent laparoscopy 4 days ago. Now she's complaining of abdominal pain. Her abdomen is lax. There's a temperature of 38. Pulse is 100 millis. Blood pressure is 130/80. Abdominal ultrasound showed intra-abdominal collections, but it's minimal, and bilirubin is 15. So I'm
So
taking.
this bilirubin is normal. Okay. All right. So what is the possibility you have?
It might
What
be
is
a
the possibility of this condition?
It's bile leak, like there is a slip.
Yes, I know bile leak, but what is the cause of this bile leak? What it could be?
A slip step.
A slip suture from cystic duct can. What else?
Injury to the common bile duct.
Injury common bile duct. What else?
And I don't know.
Can be ligated common bile duct, or can be slip ligature, can be accessory duct, can be leakage from liver bed, can be injury or missed common bile duct stone.
Okay.
Okay, all right. So if the patient in obstructive jaundice or not?
No, because the jaundice is normal. The bilirubin
You
is
mean
normal.
bilirubin is normal
Yeah.
and the urine
bilirubin-
is normal. So it's not in obstructive jaundice. Okay, that's good. So how do you know that? Because of the bilirubin, direct bilirubin. Which bilirubin is increased in obstructive jaundice?
It's direct bilirubin.
And what is the normal bilirubin level? Usually?
It's 1 to 1.5.
No, it is usually 1 milligram, yes. 1 milligram, you use milligram in Egypt, but it is okay. It is 15 millimole, so 1 milligram is okay. All right. Okay. So what the cause of jaundice now? If it is jaundice, what could be?
Obstructive of the common
Yeah,
bile
what
duct.
is the cause of obstruction if the patient have obstructive jaundice? Not your patient, we speak in general.
Yeah, generally if there is head pancreas.
No, we speak in general in the patient, not after surgery. After laparoscopic surgery, if patient develop obstructive jaundice, what the possibility?
It might be, what's the cause or what's the possibility for the patient to have?
What is the possible cause?
Okay.
What is the cause? Yes.
Ligation of the common bile duct.
Ligation of common bile duct or slipped stone. Okay. So this is if have recent. Suppose the patient have obstructive jaundice, the same patient after laparoscopic cholecystectomy, but after 1 month, what it could be?
Retained stone.
No, retained stone, not stayed 1 month.
It might be stricture.
What is the cause of this stricture?
Injury to the common bile duct.
Okay, so if you have injury at time of surgery, usually obstruction occur after 1 month or late or after few weeks, but you have slipped stone, the jaundice occur, they have a drain. Okay, so it is good to put a drain because if he put a drain, so you can know this is bile or not. Okay. So why you put a drain? Because usually we don't put a drain after laparoscopic cholecystectomy. When usually you put a drain after laparoscopic cholecystectomy, it's not common. Why he put in this case? What you expected?
If the surgeon expected that he might be there is an accessory duct he didn't ligate, or there is
accessory duct or have a lot of adhesion or difficult, so he put a drain. Okay. All right. So this patient can develop the biliary peritonitis or not?
Yeah, can.
No. Why no? Because the patient already have a drain, so no biliary peritonitis. So already the bile is come from the drain. Okay, so it's difficult to have biliary peritonitis. Okay, so suppose this patient don't have a drain. So what you will do and the patient to don't develop biliary peritonitis?
To go with the percutaneous ultrasound guided to withdraw that bile out from the abdominal.
All right. So can you tell me what is your management now? How to manage this patient?
Okay.
So the patient already have a drain and maybe minimal injury. So how to manage this patient?
I'll start with his airway, breathing, and circulation.
No, airway, doctor, relax. Airway is not a trauma patient. It is not a trauma patient. Okay. We start by intravenous, not airway.
Okay.
Intravenous fluid. What else?
Intravenous fluid to support his circulation.
Okay. Intravenous fluid and?
For pain management, I give him
analgesic, but avoid some hepatotoxic. What else? Antibiotic.
I will check antibiotic, and I will start with the ERCB.
ERCB or MRCB. Okay. So how many antibiotics you give usually in this patient?
Triple antibiotics for gram-positive, gram-negative.
No, we don't have triple. We usually give aerobic and anaerobic. We give cephalosporin and metronidazole. We don't have triple antibiotic. So you can have MRCB or ERCB. Usually, what is the difference between both and what you prefer?
If I'm just if I don't know the diagnosis, I'll start with MRCB because MRCB it's not invasive.
Diagnostic non-invasive, but suppose the patient have a stone or have a stricture, what you will do?
I will start with the ERCB because it's diagnostic and therapeutic at the same time.
What you do if you have a stone?
ERCB, because
No,
ERCB
what you do with ERCB?
removal of stone.
By ERCB.
Yes,
If it is difficult to remove it, what you will do?
put a stent.
Put a stent. Okay. If the patient already have a stricture, what you will do?
I think we'll do. We'll put the common bile duct into the intestine.
No, this is historical also. Kasai operation and Roux-en-Y hepatocoagulopathy is historical, is not done maybe in the last 20 years, but he just put a stent, but at this time he leaves the stent for a long time. Okay, now we have self-expanded metallic stent. Okay, at the end, what you need to tell me?
I tell you that we have checked the patient drain, and there is minimal. I did the ultrasound, and I started by fluid resuscitation for the patient's antibiotic and analgesia, and I will check his vital signs and drain every 4 hours.
Yes.
To tell you,
And the book for or follow up for
ERCB
MRCB or ER.
or MRCB.
Okay, all
Thank
right.
you.
So it is easy station. The clue in this station just to know if the patient develop jaundice after 1 month, it is stricture due to injury of common bile duct. If the patient developed sudden obstructive jaundice or bile leakage just 1 week or within few days after operation, most probably is injury of the common bile duct or slip lecture from cystic duct or slipped stone in common bile duct below the level of the cystic duct, so the bile come from the liver and come out from the cystic duct. Okay.
Okay.
It is easy scenario. Any comment from anyone? After that, we have a head trauma. Okay. I found difficult to share. I don't know why. Okay. Anyone or Dr. Nabhan again? No problem.
Can I try this time?
Okay, can Dr. Mariam. You are Dr. Richard, SHO in emergency. We'll make it Mariam now. And
By the way,
you will
although
call
Dr.
Mr.
Mariam is just young graduated, but she is professional in answering the exam. So
All right,
she can
okay.
give an example to candidate, and I wish you good luck, Dr. Mariam.
Okay.
Thank you.
The consultant in charge today to tell him about trauma case. So what you have 35 years old man come to emergency department after RTA road traffic accident 30 minutes ago. Glasgow coma scale is 15 at time of arrival. Blood pressure is 130 over 80 millimeter mercury. Pulse is 100 per minute, and he has left open fracture tibia. No pulse in the left dorsalis pedis artery. Just review the scenario, and after that we start soon. Okay. We leave the scenario like this, and
Can you give this? Can you see the scenario, Dr. Mariam?
Yes,
Yes.
Very
Okay.
good.
So you can start. You can just introduce yourself.
Hello, good evening. I am
good evening.
Dr. Mariam.
Yes.
I am the surgical HO on call right now. May I confirm who I'm speaking to?
Yeah, I am Mr. Browse. I am the consultant, trauma consultant, or accident and emergency consultant in charge today.
Can I take a minute of your time to inform one case?
Okay,
to you?
can. No,
Okay, so
yes.
I have one 35-year-old man who came around 30 minutes ago to the emergency department. He went under road traffic accident. His GCS at the time of arrival is 15. His vitals are BP is 130/80, pulse 100, and he also has a left open fracture tibia, but does not have left side dorsalis pedis pulsation.
Okay. So can you start to tell me one by one? So first, how you assist this patient?
So in the RTA cases, we will start with ABCD primary survey. I will go through airway, breathing, circulation secured, I will also, in the concurrent cervical spine also, I will check for the patient. During this time, I will assess the
So we can start one by one. So how to check the airway?
I will see if there's any lodged, any facial fractures, any lodged material in the mouth, if the patient is able to answer to me.
Okay, so
with
just
full
as the patient
sentences.
answer to you is okay.
Yes,
All right.
okay.
In the examination of the face, I show you the picture.
Okay, so
What is this?
that is the Bethel sign.
What did it indicate?
It indicates a fracture in the temporal.
No, not temporal. It is
This is
fracture
the
base.
base of
Base
the
of
skull
skull.
fracture. Sorry, base of
But
skull
this is called the
fracture.
battle sign.
Bethel
And
sign.
also we have raccoon eye. It is
Raccoon eye.
indication of the fracture base
Frontal.
of the skull.
Raccoon is frontal, yes.
Okay, so after the airway, you go to for breathing. How to check the breathing?
So observe the chest wall movement, if it is bilateral, equal entry or present or not, or if there's any restriction. I will also check the location of the trachea, if it is central or not.
If it is deviated to other side, what it means?
Then I would go on to auscultate the chest and percuss to confirm if there's any tension pneumothorax.
All right, okay. So A, B, C, what is C?
C is circulation. I make sure the patient has 2 white bore cannulas and start the patient.
What usually is the color of white bore cannula?
Green color. Green or gray
Green
color.
color, it means 16, 18, green or gray. Okay, yeah. What else?
Then I will also, like I said, GCS and pupils.
Okay, so we start by good glaucoma scale. Glaucoma scale is out of what? Is this patient is 15? So what is that maximum?
So total is 15. We can get.
Okay, so what is the component of glaucoma scale? We have eye out of
eye opening, verbal, best verbal, and best motor.
So eye from how many mark? Like
eye is from E5, 5 marks.
No, eye is 4. Eye is 4.
Sorry, eye is 4.
Yes.
Verbal. V5 and M6.
All right. Okay. So its total is 16. Yes. All right. So if the patient have extradural, which side, right side extradural, which side the pupil is dilated?
Left side.
No. Are you sure?
Right side extradural, right side, same
right side. So it is ipsilateral pupil dilated in the extradural.
Yes.
Of course, you're looking for raccoon eye, battle eye, glaucoma scale.
Yes.
And after that, we have something called amble history. What is this amble history?
So after I ensure the patient is stable and able to give allergy medication, last meal and...
No. B, bust history, and L, last meal, and E, event.
Event.
So why we ask about last meal?
So there is chance of aspiration. There is chance for going to op if the patient needs emergency op.
So if the patient is just eating before accident, what you need to do to him?
NG tube, we have to put a nasogastric.
What does NG tube mean?
Nasogastric tube for
nasogastric
lavage
tube.
of the stomach.
Of course, this is glaucoma scare, just to remember. After that, what is the routine X-ray we do for the patient?
So we will do chest X-ray, cervical spine X-ray, and also open tibia fracture. So I will get...
No, forget the tibia fracture. We already make it. What is the third classical, traditional? We have cervical, we have chest and
abdomen.
Abdomen to looking for hemorrhage or fracture. Okay. So what else you need to do to confirm that the abdomen is okay?
So I will do an E-fast scan.
What is fast scan mean?
Fast scan is focused assessment of sonographic.
It is done for how many areas? 4
areas mainly. So lung bases to see fluid collection or pleural effusion or hemorrhage or pneumonia.
No, we write it. We make it right side for liver, left side for spleen, middle for cardiac tamponade, and the lower for free fluid.
Yes.
Okay, I show you the X-ray, but this is X-ray is historical because it is not in the same patient. So one is extradural, one is subdural. What is the cause of extradural hemorrhage?
Extradural hemorrhage is usually middle meningeal artery in the injury over the pterion region.
Okay, what is the cause of the subdural?
Subdural is drainage, venous.
Venous. So as you see, usually subdural is venous, extradural is arterial. After that, you mentioned that the patient have a problem in his lower limb, and you mentioned that his pulsation is weak. How to confirm the pulsation is weak?
I will do a bedside Doppler if it is available.
Handhold Doppler. No, it is available. Okay, so you do handhold Dopplers and you don't found it. So what you need to do now?
So for the fracture, open
First,
fracture,
you mentioned it is open fracture. What does mean?
yes, open fracture means there is a breach of skin and breach of
Okay,
skin
so
and
usually in
exposure
open
of the bone.
fracture, we have comminuted fracture. What's comminuted fracture?
That means two segments of the bone are there.
Okay, so not necessary to be open. Open is skin loss and comminuted more than fragment.
No.
So they usually in open fracture, what type of fixation? Just tell me first, we have internal, external, and the Elizarov. In this patient with open fracture, what type of fixation you will do?
External.
External fixation.
External fixation.
Okay, so just tell me what is your plan for this patient after ABC and stabilize the patient and the Glasgow Coma scale is okay. What is your plan now, or what is your strategy now?
I will get ortho to stabilize the open fracture and put. But in the meantime, I will also ask for a CT because Bethel sign and Raccoon sign was there.
No, just forget the CT. We make a CT, and it is important. But you ask an orthopedic is not the proper. You need someone with him because the patient have vascular injury.
Yes. Yes.
So you need a vascular injury. This is example of the external fixator.
Okay.
And this is example of external fixator, but the important to make a vascular reconstruction. Yes. Intraoperative, you can do angio. This is the angio of the patient. Okay, what you see in this angio?
So I think that's
this is a
femoral
and suddenly popliteal become not good. Yeah. So this patient have something in the popliteal area.
Yeah.
Okay. So if you bring the vascular and orthopedic, who will start first?
Vascular.
Vascular. Okay. Yeah. And waiting till fixation, and usually fixation is external fixation. Why it is external fixation again?
Because open fracture and
because of what?
Open and comminuted fracture.
Okay, because of open, mainly for open. Yes. Okay. All right. So just to summarize to me what you need to tell me now. What is the end result of this conversation?
My patient,
we already, the patient is stabilized, ABCD, everything is okay, but we have a problem of his leg. So what you will do?
So I have already informed anesthesia, booked the OT, and arranged blood for the patient. And I have informed the vascular team and orthopedic team to start on the op as needed.
Okay, thank you. You need to thank the consultant
at the end. Thank you for your time.
Okay. All right. So as you see, although this station is mainly ABCD, but we concentrate here in the vascular injury. Of course, open fracture is mean loss of skin. Comminuted is more than fragment. If you have open skin more than 1 centimeter, it's better to have extradural, external fixator. And of course, vascular surgeon must be present. Sometimes the intraoperative angiogram done. Of course, you speak about EBC. It is important to know Glasgow scale. All this is important to know what we called it fast scan and the area of fast scan. Okay. The next scenario is speaking to registrar to book post-operative bed. And this is also common. I will just share the screen. Anyone need to share or to speak? I share. Okay. Anyone? It is just to book a place. Yes, okay. All right. So book post-operative. It is you are Richard again, or can you write tell your name? And for Mr. Parsons, you call Mr. Charles. Mr. Charles is intensive trauma care or intensive trauma unit registrar to tell him to booking for a post-operative case. Okay. After just this is a scenario, you have 73 years old woman, have a sudden abdominal pain, confused, on examination, suspected perforated viscous or perforated peptic ulcer, laparotomy, urgent laparotomy done. Usually repair of perforated peptic ulcer is not major operation, but this patient have chronic obstructive airway disease, have acute kidney injury or acute renal failure, and she is on dialysis. Potassium is 4, which is little high. Creatinine is 3, which is okay. Arterial blood gases I show to you. ECG also I show to you, and the X-ray. So first you speak to the consultant and to confirm. We can start?
Yes, we can start.
Yes, okay.
Good evening. My name is Dr. Richard. May I confirm that I'm talking to the
Yes, I am
ICU
Dr.
consultant?
Browse. I am the intensive trauma care unit registrar in charge.
Good evening, Doctor.
Yes.
May I take a little bit of your time?
Okay, can.
Okay, I'm talking to you to talk after surgery bid for a patient 73 years old, had a sudden
Yes.
abdominal pain, and it was suspected perforated viscous. Urgent laparotomy was done.
Okay, but doctor, you know that it is just perforated duodenal ulcer. It is very common and easy operation. You just make 3 stitch and that's it. This operation take 5 minutes. So why you need the patient to be in the intensive care or trauma care?
Yes, as the patient have other comorbidities, she is COPD, acute renal failure on dialysis. Her blood investigations reveal the potassium is 4 millimole. Her
It is
creatinine
mean
is-
high, so it means that they have high potassium and she is chronic. So the indication of admission is for what? For comorbidity.
yes.
Okay. All right. So I just show you the blood gases. Can you comment on these blood gases for the patient?
Yeah, the pH is low, so the patient is having acidosis. The
Yes.
bicarb is low, so and the CO2 is within normal, so the patient is having metabolic acidosis.
Okay, I show you also the chest X-ray. This is just pre-operative. What you see in this X-ray?
Yeah, air under right dome of diaphragm, the perforated peptic ulcer is suspected.
Okay, I show you the ECG. Maybe complicated, maybe have a nice picture, but it's okay. ECG is within normal, by the way. Okay, so perforated viscous is a minor case, as I mentioned, so you need it because of the comorbidity. So, we have intensive care and HDU. What is the difference? What is ICU?
It's intensive care unit.
Yeah, what is the difference between intensive care and HDU in England or other space?
Yeah, in ICU,
Yes.
a nurse is taking 2 to 3 patients, and HDU, the nurse is taking 1 patient per nurse.
No, the reverse. Intensive care unit, the nurse is taking care for 1 patient. So 1 nurse to 1 patient, ICU. HDU is 1 nurse to 3 to 4 patient. In Scotland, they called it a step-down unit. So step-down unit or HD unit, high dependency unit, means that it is 1 nurse to 3 patients. Okay, so can you tell me in general, what is the criteria to admit the patient in ICU or ITU in general?
Yeah, if the patient have comorbidities,
Like what?
like chronic disease, COPD, renal failure,
Okay, can.
cardiac problems.
All right. How to know severity of cardiac problem? You mentioned cardiac problem. For example, in surgical, what is the easy way to evaluate the cardiac condition of the patient?
Echocardiogram.
What you looking in the echocardiogram?
If the patient having a heart disease.
No,
or
looking for what? Looking for only 1 parameter. Use it in surgery, which is
ejection fraction.
ejection fraction, which is normally equal
65.
65. Okay. So the patient admitted ICU is a patient need close monitoring or have comorbidity, uncontrolled diabetes, uncontrolled hypertension, heart problem, renal failure, respiratory support, patient on ventilator, or any organ failure. Okay. So about this case, you show me arterial blood gases. Can you tell me how to take arterial blood gases sample?
Yeah, from the radial artery or from the femoral artery.
From the femoral artery. Okay. So what type of syringe you use to take arterial blood gases? Like what you put in the yes, heparinized syringe. Okay. All right. Okay. After that, erect X-ray. We show the X-ray again. So this is the X-ray perforated viscous. Maybe this clear picture of ECG. What's your diagnosis?
Absent P wave. There is
Absent or multiple. What is your diagnosis?
AF.
Atrial fibrillation. Okay. So if the patient have atrial fibrillation, what it mean?
It means that the heart
No, is this usually in atrial fibrillation? What you give medication, routine medication to the patient?
to control the rhythm, beta blockers.
No, forget the cardiology. I'm not expert in cardiology. I speak from surgical point of view. Usually, any patient for AF, you give him what to protect
anticoagulants. Anticoagulant to prevent thrombosis and embolus.
So take care. This patient maybe have anticoagulant, and also in dialysis, usually they give heparin. Okay. So, but I don't have any bed empty in my clinic, in my intensive care. But I see that you have 5 patients in ICU. Can you give me any suggestion? What you will do?
If there is any patient, can just back to the ward. We can just.
Okay, so you come and looking for any patient, maybe some stable, you can send him to HDU, high dependence unit. Of course, you don't send him back home. Okay. All right. So can you summarize what is the end of our result?
Yes, the patient had his surgery and I booked a.
Although it is minor surgery, but because of the comorbidity, I prefer to admit him in the intensive care. And this patient, because I know that you don't have a bed, so what you will do?
We will try to find a bed for other stable patient in the HDU, and if there is no way, I can just try to transfer him to other hospital that have.
No, just don't be more suggestion. You can find it is easy. You have 5 patients, so it is maybe some of them is stable, so you can transfer one of him to the HDU or the ward, and you have empty bed for your critical patient. Okay.
Okay. Thank you.
Thank you. The last scenario phone call. This is a common phone call. Have the last scenario calling for vascular consultant to tell him about ischemic limb.
Okay, I'm volunteer.
Okay, Dr. Yassin, you are welcome. So what we have, of course, it is the same. You're looking for the vascular consultant in charge today. And this is the scenario, is 65 years old, chronic smoker with abdominal pain, complaining from sudden acute left lower limb pain, history of pain. He is in walking, improve, wine stop 5 minutes. He's hypertensive on Brondobile. Brondobile is AC inhibitor, and also have AF, but not in any treatment now, which is wrong. Vital sign is normal, except 100 per minute is a pulse, a regular heart, a regular chest. I don't know. No, the irregular is a pulse is irregular because of the AF. Chest, heart is normal, and abdomen is lax. On examination, left leg is cold, loss of hair, loss of sensation, peripheral pulsation is weak, arterial blood gases, and ECG is attached. Okay, so you can speak to me first. Can I start?
Yes, hi, Doctor. I am Dr. Yassin. Can I confirm your name, please?
Yes, I am Dr. Arsar, the vascular consultant in charge for today. What you have, Dr. Yassin?
Doctor, please, I have one patient in ER, came to me, 65 years old, smoker, with sudden onset of left lower limb pain, and he is known to be on antihypertensive
Brendobile. It is AC inhibitor. In some country, they called it Coversil.
Yeah, and he's known to be atrial fibrillation, but he's not on treatment.
Okay, so if the patient have atrial fibrillation, what you expected, what happened to him?
Maybe there is thrombus lodged down to the femoral organ.
Okay, all right. So I show you the arterial blood gases of the patient. What's your diagnosis?
pH is low, that means acidosis, and bicarb is low. This is metabolic acidosis.
Okay, and again, this is ECG of him, and it is AF. All right. So just I confirm, what investigation, you mentioned this patient have ischemia or something in his lower limb, but what the investigation proves that? Of course, clinically, it is look like clinically first. What your diagnosis clinically?
This may be acute left lower limb ischemia.
Okay, so what next step you need to do?
I can do CT angio or ultrasound Doppler.
Okay, this is the angio of the patient, arteriogram, left side. What you see in the angio?
There is abrupt of the dye down in the SFA.
You mean that's a superficial
superficial
femoral artery?
Yes.
Okay. What is the common site you can have thrombosis in the lower limb?
Common
This
site.
one. This is the common site.
Yeah, near the popliteal artery.
Oh, beginning of popliteal artery. Okay. All right. So, pain in walking. So you mentioned this patient have pain during walking. What with this pain we called it?
Ischemic pain.
Ischemic. But this patient, he say he walking improve when he stop 5 minutes. Claudication pain. So this patient have something what we call it intermittent claudication pain. All right. So you need to do a scan of the abdomen or not? CT or abdominal scan or ultrasound for the scan or not?
Yes, I will do CT angio from lower abdominal aorta till both lower limb artery.
We don't need angio. You can just make CT or CT angio or CT of the abdomen looking for aorta. Is this patient can have mesenteric vascular occlusion?
Yes, can be.
With mesenteric occlusion, but not now. Okay. Of course, we show you the arterial blood gases and the others. Okay. So we make the ECG again. We found this picture. What this picture could be?
U wave. This mean hypokalemia.
Hypokalemic. So this patient is hypokalemic. Okay. So can be also hypokalemic. It's not related.
Yes.
Okay. All right. So why dorsalis pedis is felt although the popliteal artery? With this picture, the dorsalis pedis we felt it weak. Is not absent.
Maybe
Why?
The doctor pulse. Maybe.
No, not the doctor pulse because they have good collateral. You can see here they have the flow down.
Yeah.
It is not complete abrupt. It is still have something. Don't say some fun in exam. Okay. So what is your management plan now?
I will call the vascular team to see the patient and do any intervention from their side.
What do you mean by intervention?
Maybe thrombectomy.
Thrombectomy, balloon dilatation.
Yes, balloon dilatation or bypass.
What is called? Okay, if it is failed, they can put a stent. Yes. Okay, will you tell the family or not?
I will tell my senior.
No, we speak about suppose you are the senior, you are the only doctor in duty now. So yes, you tell the patient family or not?
I will tell them about what I see, and I will tell them I will call the team needed for this patient, the vascular team.
You mean vascular team? Okay, so who signs the consent in this patient?
The vascular team.
No, who will sign the consent?
The consent will be signed by the patient because he's alert.
Okay, so the consent is signed by the patient. So what is your management plan? You give analgesia, you correct hypokalemia, you treat atrial fibrillation, you're looking for anticoagulant INR, collect metabolic acidosis. After that, if you examine, you can have loss of the skin and all this. This is a balloon dilatation. We can use it. And at the end, you need to summarize. Can you summarize?
Yes, this patient is a 73 years old male patient, smoker with known history of atrial fibrillation, came to the ER with a sudden onset of left lower limb acute pain, and pulses is barely palpable.
Doctor, when you summarize, we don't repeat the history. It's summarize, just tell me this patient is look like it look like have ischemia. I think someone raised his hand. We can ask him what he need to ask.
Okay.
Okay. Okay. Someone ask something. So,
If
okay,
anyone
Dr.
has a
Muhammad.
question, yes, please go ahead.
Okay. So when he summarized, we just speak about when he summarized, he don't start from the age and all this. Just this patient now is acute left lower limb ischemia, and it can be urgent. And we ask the consultant team for angio and angioplasty or putting a stent, and I check for anticoagulant and all this. But not to start from the beginning, except if the beginning something very important or related or critical. Dr. Shahat, you need to ask, or Dr. Muhammad, I forget the names.
No, I just raised my hand. I think if there is another session, I wanted to join.
Okay, all right. Okay, thank you. Okay, we're about to finish, by the way. All right. Yes, I think this is the last one. I just to confirm, because this is the 7th, this is the last one. Okay, so what I need to tell you, when you summarize at the end, if you summarize at the end, what you need to tell, you need to tell the summary, not the summary of the history. It is not history taking, and you summarize the history. We don't have actually in the Royal College, except in some station, something like this, because usually we observe you, we are in the small room and observe you during you take a history taking. Okay, so that usually we follow up you during history taking, but when you summarize, you just what is the positive data. So the positive data, we prepare the theater, I prepare the vascular team and the orthopedic team, I alert the scrub nurse in the theater. In this patient, for example, I